This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. Welcome, everybody, to another episode of PHM from Pittsburgh. I am still your host, Dr. Tony Tarchichi. For those of you who are new, I'm a Med-Peds-trained pediatric hospitalist here at UPMC Children's Hospital of Pittsburgh in the Paul C. Gaffney Division of Pediatric Hospital Medicine. We have been coming to you since 2016, going through the Pediatric Hospital Medicine content specifications, and then, of course, talking through topics that come up in the world, like the pandemic we're still in, and now this new topic. So for those of you who are new, remember there's free CME associated with this podcast. Click at the link at the bottom of the description, courtesy of the University of Pittsburgh. So thank you, University of Pittsburgh. Today's topic has been in the news. It's been everywhere now. And really, I don't know much about it, and I want to talk about it. And that's one of the reasons I have the podcast, is so I can get smarter. And hopefully you guys learn a little something and are entertained. But there is now a second widespread virus that's going across the country that is getting a lot of attention besides COVID, and we need to talk about it a little bit. So monkeypox is what we're talking about. Now, just to start out, appropriately so, the WHO says it would like to rename monkeypox to avoid discrimination and stigmatization. We have not, a new name has not been chosen, so while we're talking about it, we will use the term monkeypox, but once it's changed, we'll, of course, use whatever term WHO and CDC want to use. So for now, I want to introduce our expert guest because I don't know enough about this to at all talk about it. And I'm very fortunate and happy to be joined by Dr. Anita McElroy. Dr. Anita McElroy is an assistant professor here of pediatrics at the University of Pittsburgh and a board-certified pediatric infectious disease doctor here at UPMC Children's Hospital of Pittsburgh. She has a special interest in emerging and exotic viruses. She has over 20 years of experience working in the BSL-3 and BSL-4 containment lab, studying viruses such as Ebola, Crimean Congo hemorrhagic fever virus, and Lassa virus. She runs a research lab at the University of Pittsburgh studying the immunity and pathogenesis of Rift Valley fever virus, which, like monkeypox, is a zoonotic virus that is prevalent in Africa that requires BSL-3 containment. And today she's going to help us understand what monkeypox is, what to be on the lookout for to identify it in patients, and how the disease can be prevented and treated. So, Dr. McElroy, thank you for joining us.
Thanks, Tony. Happy to be here.
So let's get our conflict of interest statements out of the way first. Anita, I will go first and then kick it out to you. I have nothing to disclose.
I also have nothing to disclose.
So, Anita, when I prepare for these podcasts on infectious disease, I like to read up a little. So the first place I always go is the AAP Red Book. That's like a tried and true for most pediatricians when there's an infectious disease, something going around. I went to the AAP Red Book online. I typed in monkeypox. First, nothing came up. So then I typed it again I Googled it, but I went to the actual Red Book itself, and smallpox came up. And under smallpox, there's a couple of paragraphs on monkeypox talking about the 2003 outbreak with guinea pigs, I believe. But there is not much on this in the Red Book.
Absolutely, you're right.
So why are we talking about this, Anita, and how widespread is this, and how do we think this started?
Yeah, it's a really fascinating topic, Tony. I'm glad that we're talking about it today. Since May of this year, so 2022, there have been reports around the globe of cases of a vesicular rash that was pretty rapidly identified as monkeypox. There are over 2,000 cases at this point reported from 36 different countries, and we've also had spread to the United States as well. And as of yesterday, June 15th, we had 83 cases reported in the U.S. As you know, monkeypox is endemic to Africa, to West Africa, and to Central Africa. And it doesn't normally exist or cause disease outside of those locations. The exceptions are rarely there will be travel-related importations, and that's happened twice previously in the United States where someone has traveled to Nigeria and then come to the United States and been diagnosed with monkeypox. That happened twice in 2021. And then, as you mentioned, the importation of rodents from Africa that were co-housed with pet prairie dogs in 2003. That was the incidence where we had 47 cases here in the United States. And that was the first time that the virus had actually ever been reported outside of Africa when we had that outbreak here in the U.S. And interestingly enough, there was lots of cases related to people contacting those infected animals and becoming infected themselves.
So, is monkeypox is a virus? Can you walk us through what type, how it works?
So virologists, when we think about viruses, we talk about them in terms of their nucleic acids. So this is a DNA virus, not an RNA virus. So it's a double-stranded DNA virus, and it's in the Poxviridae family. So the other pox viruses that people would be familiar with are smallpox, right? Most commonly. There's another virus called ORF that people might have heard about, some of your listeners. Importantly, chicken pox is actually not a pox, right? Chicken pox virus is varicella zoster virus, which is a herpes virus. So we want to make sure we make that distinction for everyone. And these viruses are double-stranded DNA viruses. They're very large. They have very large genomes, and they have an envelope, so a lipid bilayer that surrounds them. And that's important because it helps you understand how labile it might be to disinfectants.
So now, how easily, you said the previous case, the prairie dogs, we had 47 cases in the U.S., which is more than half of the number of cases we currently have, which said 80 something.
Mm-hmm.
So that was a pretty sizable outbreak. How easily is this passed? And now that we have all of this COVID experience, is this spread as easily as COVID or even measles, and is it easily contained?
Yeah, very different. So it's important for everybody to understand that there's no data to support aerosol spread of monkeypox. Okay, so let's just put that out there from the get-go. Most pox viruses are spread from animal reservoir to person. So like in the case of the prairie dogs, people got it directly from their prairie dogs. And it's usually by contact with those infected lesions that are present on the skin. And I know we're going to talk a little bit about the lesions themselves. It can also be spread by contact with infected primates, right? This is why it's called monkeypox. It was first identified in the 1950s in a monkey, and it can spread from those lesions on the monkey to people. Now, occasionally people will consume bushmeat in other parts of the globe, and it's possible that there could be acquisition of disease by consumption of contaminated meat. But typically it's spread from animal to person.
So now when we talk about bushmeat, is there any way you could be more specific? Because here in the U.S., I know there's people who like buffalo and elk or wild game like that, duck. Are we talking about that or something different?
We're typically talking about non-human primates that are consumed for food. Also, there are other animals that might be found sort of literally in the bush, right, in the wild, that are consumed for sustenance.
Okay. So now, what's the incubation period for this? From the time if you're going to get it, from the time you're exposed to you show symptoms?
Yeah, usually it's a 1 to 2 weeks incubation period, but it can be anywhere from 5 days all the way to 21 days.
Oh, it's a wide range. Okay.
Yes.
So now, what are the initial clinical symptoms look like? What can they become?
So typically, a patient would experience fever, headaches, myalgias, all very nonspecific, unfortunately. One thing that might help the clinician out is that a lot of reports of lymphadenopathy are very prominent in cases of monkeypox. So if you're looking at a patient who seems to have a lot of lymphadenopathy, that might be the patient that you want to pay attention to. And the lesions, the skin rash, doesn't develop until 1 to 3 days after the onset of the fever. So you have a timeline to sort of help you gauge when you should be expecting to see those types of lesions.
So fever and malaise, headache, and then lymphadenopathy, that's clearly obvious, 1 to 3 days later. Is the rash called pox blisters, or is there a name for this rash?
I typically refer to them as lesions, but
Lesions, okay.
yeah, they can be blister-like, but they have quite a lot of variability in how the lesions themselves can present. So you can have macules, you can have papules, vesicles. They can become pustular, and then ultimately they scab over. So they go through sort of a natural progression. And you might not see the patient when they are at the vesicular stage, right? You might see them prior to or after that.
Okay. And since we're talking to pediatric hospitalists, do kids manifest like adults, or are they more or less severe?
Kids are probably more at risk for potentially a couple reasons. So,
Okay.
um, lack of immunity is one. So, you'll recall that we used to give the smallpox vaccination, right,
Mhm.
all around the globe and in the US as well. And as our population ages, we still have older people who had at some point in their lifetime received that vaccine. But
Okay.
we stopped giving that vaccine when smallpox was eradicated in 1980. So, all of the younger generations don't have that vaccine. And if you look at cases in the parts of the world that are largely affected by monkeypox, specifically the Democratic Republic of Congo, there's been quite a bit of studies done there. Kids are highly represented in cases that are identified, and the hypothesis is probably because no one's doing routine immunization anymore, so they don't have that protection.
Okay.
And when kids do get infected, they are potentially more likely to get sick. So in that 2003 prairie dog outbreak that we had in the US, 50% of the pediatric patients were hospitalized, but
Oh,
only 9% of the adult patients were hospitalized. And some of them required ICU level care. So kids can get sicker potentially than adults.
so now, as you know, I'm a pediatric hospitalist. When I have kids come in, right now, and as you know as well, we've had this weird year where viruses no longer have seasons and they stay forever. So we still have flu. We're still having. I just admitted recently RSV. So stuff that should be long gone is now still here. So everyone's coming in with fever, malaise, and headache. Just about every patient I have
Yep.
has those three symptoms. Should I spend some time with the CDC website looking at these pox blisters, and then that's when I should be concerned about it? Or when would you recommend a hospitalist be concerned that their patient may have contracted smallpox?
Yes. Monkeypox. Monkeypox.
Monkeypox, I'm sorry. Oh, God.
Fortunately, smallpox should not be something that we have
Oh,
to
God.
deal with.
Yeah, I don't want to deal with that now. We got enough going on, Anita.
Absolutely. So I would say your history, right? As a good ID doc, it's my job to say the history is key, right? And in this case, it absolutely is. So, do you have a patient who has traveled to a part of the globe that has ongoing monkeypox cases, right? So you could look on the CDC website and see where the cases are in the United States, or you could look and see where they are globally. And then you could use that as a gauge to think about, is it possible this patient could have even been exposed to monkeypox? The other thing I would ask is exposure history with an animal contact focus, right? If you want to think about, do they have exotic imported pets? So after that big outbreak that happened in 2003, CDC actually banned importation of African rodents. So
Oh,
that exists to this day that people are not permitted to bring African rodents into the country because of that outbreak. So that doesn't mean it doesn't happen though, right? So
right.
sometimes people do things that they're not supposed to do. So asking about exotic pets in the house, whether they be rodents or even non-human primates, it sounds crazy, but we literally had a patient on our service not that long ago whose family had a monkey in their home, which is illegal, of course, right? But
Yeah.
this happens. It still happens. So asking that question, is there an exotic pet in the household, would be a really important factor when you're getting your history. And then if you have the rash, yes, absolutely, you can look at the rash and you can go to the CDC website and look at pictures of the rash. So if you just go to your search engine and you type in CDC monkeypox, and it will immediately take you to the main website. You can click on the link for healthcare providers and see pictures of the rash.
Okay. Yeah. Yeah. You're right. I mean, the black market exists for a reason. People can get I guess whatever they want whenever they want. So now, in our part of our listenership is community hospitals, pediatric hospitals. They may or may not have pediatric infectious disease assistants. Sometimes they have adult ID assistants that will help them out in a situation. If I'm in a community hospital and I'm concerned for monkeypox, is this a patient I should just transfer? Should I talk to whomever? Should I call my local health department? What do you recommend?
Yeah, I guess there's a couple things to touch on there. So, the recommendations for diagnosis we'll talk about, but caring for a patient really require essentially COVID style PPE. So, you're going to be wearing a solid front gown, you're going to be wearing gloves, you're going to be wearing eye protection and an N95. It does not require airborne precautions. So, you don't need a negative pressure room. So, if your facility can handle providing that type of PPE for your staff, and they're trained to use it. And you can put the patient in an independent room, so a single patient per room, and the door stays closed. Then there's no reason you couldn't care for that patient in your hospital. We oftentimes in our ID service at UPMC Children's field calls from the community, from hospitals that don't have access to a PDID specialist, and we help them out on a regular basis over the phone. So I think if you can provide those things to your patient, then it's reasonable to think that you could care for them at your hospital. Now, with that said, there is the potential for diagnosis and treatment, and you have to call your local public health department to coordinate that. So as long as you have a local public health department that can work with you to coordinate getting the samples for diagnosis and helping you get access to treatments or vaccination if it's needed, then I think you could manage them in your facility.
That's a great intro to what we're going to talk about next. So what testing is sent to diagnose this?
So you should get samples from more than one lesion. The idea is to pretty vigorously with a swab, a Dacron swab or polyester swab, rub the lesion and then put it into a dry vial. So you might be familiar when we take samples from other types of sources where we're looking for viruses that we often put the sample into a viral transport media, that little pink media. You are not supposed to do that with this. Okay. CDC and the Laboratory Response Network, the people who would do the actual testing, they want a dry sample. So just keep that in mind. And if the scab or the top comes off, even better. Stick that thing in the tube.
Okay. And then so we send it to, and then we'll call our local health department. They'll run it. And is there treatment for this? And what is it?
Yes, there are several options for treatment, actually. Before we talk, Tony, about diagnosis and who to call, I want to make sure that you have and your listeners have this phone number. So if you have your cell phone, get it out, right? I encourage everybody, give you a second, get your cell phone out and put this phone number into your contacts. It is the CDC Emergency Operations Center. It is useful not only for monkeypox, but for any area in which you need expert consultation, right? This is what our tax dollars go to. It is important that you use the CDC. They have expert epidemiologists on all kinds of areas, and you just call them up and you say, I need to speak with the expert on Q fever, the expert on monkeypox, the expert on hemorrhagic fever viruses, and you will get that person. Okay. So this is the number 770 488 7100. I have that in my cell phone. I encourage everybody who might need to reach out to an expert there to have that number on speed dial so that you can call them if you need them. And what they can do is they can get you access to treatment and they can help you think about your patient. So if it's not monkeypox and it's not straightforward and clear, then they can help you think about what other diagnostic tests you need to do, et cetera. So if you need those guys, definitely call them. The two treatments that are available are two antivirals. One is specifically FDA approved for treatment of smallpox, which of course we don't see and don't expect to see, but it's in the stockpile. It's called tecovirimat or TPOXX. And there's an expanded access protocol that allows CDC to give you this drug from the stockpile for use for treating monkeypox. So if you have a confirmed case, you can get this drug from them. Now, you have to call CDC Emergency Operations Center to get that drug, right? You have to consult with them. You have to get signed consent from the patient's family or the patient themselves if they're old enough. And you have to fill out a series of forms to use this drug because it's considered an investigational new drug because it's not licensed for monkeypox, right? It's licensed for smallpox. So you can get that drug. And it is recommended to be used in patients who have severe disease, if they're immunocompromised, if they have a history of atopic dermatitis, because these skin lesions can be really bad for patients with eczema or underlying atopic derm, and for kids under 8 years of age. So this is important for your listeners who are pediatric hospitalists, right? If you have a kid who's under 8 years of age and you're worried that they are more likely to have severe disease, then you would want to try to get this drug for them. Also, other kind of comorbidities, if there's a secondary infection or a pneumonia in your patient, you probably want to try to get them access to this drug. That's drug number one.
Okay.
There's a second drug called cidofovir, which you'll be familiar with, right? Most tertiary care centers have cidofovir. We use it to treat CMV. It also has an expanded access protocol used for monkeypox. But if you have it in your hospital, you could use it off-label, right? You just want to confer with CDC and let them know you have a case so that they can help you make a decision about which medication you should use.
I've never heard of the CDC Emergency Operations Center, that number. That was great, Anita. Thank you. I know people will definitely use that, and we'll put it at the bottom of our podcast description so people can just see where it is there. I'm sure they'll appreciate that.
Great.
And you talked a little, since we're on a diagnosis and treatment, with the I keep saying guinea pig, with the prairie dog outbreak from 2003, about kids going to the ICU. Is it just purely for dehydration or significant secondary infection, or do you remember why they were so ill?
Yeah, there were two specific cases that stand out from that 2003 group. One child had CNS involvement, so they actually had central nervous system related disease. And then the second one had a secondary retropharyngeal abscess. So that adenopathy is really impressive. And this particular patient ended up with like a bacterial superinfection.
Oh, okay. That's helpful. Thank you. And now the scabbing that we hear about constantly, because, historically smallpox scabbing is terrible. Is the monkeypox scabbing the same? Does it cause permanent scarring?
Yeah, it absolutely can. So the lesions are really firm, right? When you touch them and you palpate them, they'll feel quite hard, and they can be pretty large. And when the lesions scab over and the skin separates and falls off, it can leave a scar. Yeah.
And are you? You said you're comfortable if people just go to the CDC website and go to the health professional section, look at the pictures there. Do you have any other, or is that the best place to see pictures of this so we know what we're looking for?
Yeah, I think that's probably the best resource. IDSA is another great resource, the Infectious Disease Society of America. That's idsociety.org. They have information on monkeypox. The WHO is also a great resource. If you just put any of these into your search browser, IDSA monkeypox, WHO monkeypox, CDC monkeypox, it's going to take you to reliable information. So I would definitely go to those resources. Another thing we should probably talk about with the lesions is they're different. And this can help you distinguish between, does my patient have chickenpox or does my patient have monkeypox, right?
Okay.
So the lesions in monkeypox should all be at a similar stage of development. So they should all look kind of the same to each other. So they're all macular, all papular, all pustular, all umbilicated, whatever. They're all very similar to one another. Whereas with varicella, you'll have some lesions pop up and then they'll evolve, and then you'll have new lesions pop up and then they'll evolve. So they're at different stages, right? When you're talking about chickenpox. But with monkeypox, they should all be very similar. And the other thing that's interesting that helps you distinguish chickenpox from monkeypox is chickenpox lesions tend to cluster on the trunk. Okay. And the monkeypox lesions tend to be in what we call a centrifugal pattern. So they're on the hands and feet, right? It's like if you take yourself and you spin, they go towards the outside.
Oh, that's helpful. And so, classically, since we're talking about this, you read chickenpox or varicella is the major differential and the differential diagnosis for monkeypox, along with, of course, smallpox that we don't see. Is there anything else that you would say is very strongly should be on a differential for these kids?
Certainly. So the only other major pox virus that we see clinically is ORF, which is usually seen in goats. It's a caprine disease. So if the patient has a history of working on a farm and having direct contact with goats, it's theoretically possible. But I would say, given how rare that is, that really chickenpox should be the thing you're trying to make the distinction between.
This is very helpful. Well, Anita, this was all of my questions. And normally at this point, I will give our expert guests an opportunity. Is there anything we did not talk about that you feel is important to talk about?
I think we should talk about vaccination.
Oh, goodness, you're right.
So there are two types of vaccines that are currently available here in the United States. And these can be used pre-exposure, right, to protect you. And they're used routinely in hospital settings or in military personnel or laboratory settings, right, where someone might have a reason to come in contact with a patient. So that's where pre-exposure happens. There is the option for post-exposure. So if you have a scenario where you had an exposure because you had a case and people didn't know it was a case, right? This happens every once in a while. And you want to provide post-exposure prophylaxis. You ideally want to do that within 4 days if you can, but you can do it up to 14 days post-exposure. So that would be something that I think your listeners would want to know. The two types of vaccine, one is the classic vaccinia, right? This is what I got when I was working in the laboratory. This is what, our parents got. I don't know. Were you vaccinated against
I was not.
smallpox as a child? Yeah. So my parents got it. It used to be called Dryvax. Now it's just a different manufacturer, and the brand name it's ACAM 2000.
Okay.
It's a weird name, but basically it's still a live attenuated vaccine, right? Derived from a virus called vaccinia, which is where we get the word vaccine from, right?
Okay.
And this vaccine is administered by taking a little drop of the liquid and doing what's called scarification. It's exactly what it sounds like. Yeah. They poke 15 times with a bifurcated needle into the skin to inoculate the vaccine into the skin. And a successful vaccination, or a take is the term they use, is when a big pustule forms right there. And that is a live attenuated virus, that vaccination. And it can be spread from person to person. So people have to keep that lesion covered. It can be spread on linens. So there have been scenarios where a husband who got vaccinated as part of his military job spread it to his wife and to their nursing infant. So people have to be careful about that. You don't give that live attenuated vaccine to immunocompromised people. You have to be a normal, healthy host in order to get that. And as you might imagine, that's a pretty scary thing for some people to think about getting that kind of vaccine. So there's been a second vaccine that was developed that is it's called Jynneos, and it is a live virus, but it's not replication competent, and it requires 2 subcutaneous injections that are given 4 weeks apart. So this is the one you would want to use in immunocompromised hosts and in individuals that maybe can't maintain that kind of sterility of their lesion from the traditional live attenuated.
I'm so surprised to hear you describe vaccine. It sounds historically like the first vaccine against smallpox, where they would take cowpox and they would just poke it on people. And it goes back to Benjamin Franklin. This goes back to like in the 1700s. It sounds exactly the same.
Jenner. Yep, absolutely.
Oh my God. Okay. And so if there were, and this is where your local health department, I'm assuming, would get involved, if there were an outbreak in your area, they would begin the vaccination process for close contacts and for people.
Yeah, these vaccines are also part of the national stockpile. So they're not routinely given to anyone, right? These are not vaccines that you can go to your local travel clinic and get. They're given in specific circumstances. So it would have to be something that was managed by your local health department in conjunction with CDC if they were going to administer this. They don't currently have a recommendation to vaccinate people in the U.S. right now, healthcare workers or providers. It's not being done routinely. So who knows if that will change, as case counts change over time.
And do you, now I'm going to ask you to look in your crystal ball here. So this is we're moving away from evidence-based science to speculation. So we're going to make that super clear. Do you expect this outbreak to spread? And because this seems more containable than, let's say, COVID was, that it's not aerosolized, that there's no respiratory droplets, do you expect this to get much wider, or this is about as big as we're going to get?
That's a good question. I mean, until we have good recognition of cases and good contact tracing, I think we may still continue to see some spread. I don't think this is finished. I mean, we still have more cases that I think will be identified. But you're right. This is containable, right? This is not an airborne virus, right? This isn't something that is going to be spread in a community, in a room, right? It's not like you get it just from being in a location with someone. This requires direct contact with the lesions. So someone's skin has to touch someone else's skin, right, for this to happen. And so that's a pretty preventable thing.
Yeah.
It's not that far-fetched to think that we can educate people about what the lesions look like and to avoid contact with people who have those lesions, and for people who have those lesions to seek out care so that they can be identified and appropriate contact tracing can be put into place.
Well, I like that a lot. So that was everything I had. And this is amazing. This was very helpful for someone like me who was reading the CDC website and being like, I need to talk to somebody to make sure I know what I should look out for. Because again, this seemed like if there was a group that was going to come across this, is going to be a pediatric hospitalist group. But as a kid comes in and then all of a sudden develops lesions. So, Anita, is there anything we missed?
The only thing that I think is worth mentioning, really just because it helps us think about which patients we should be most concerned about with this diagnosis, is there does seem to be quite a bit of spread amongst the men who have sex with men, the MSM community at this point. So I think if you have patients who fall into that category, it's really appropriate to talk with them and educate them that this is happening so that they can be on the lookout and be aware And then you can have that in the back of your mind, again, when you take your history, because your history is the most important part, where you can ask about their behaviors and activities that can help you understand if they were at risk.
Yeah, the history, I mean, here, even the pet history, which for the most part we do, and it doesn't come into play that often. Here, it's really important. Thank you very much for that, Anita. This is great. This is so good. I appreciate it so much. Thank you very much.
You're welcome, Tony. It's been my pleasure.
Time for our acknowledgments. I want to thank our special guest again. I really do appreciate your time. I want to, as always, thank the UPMC Children's Hospital of Pittsburgh, and specifically the Paul C. Gaffney Division of Pediatric Hospital Medicine for continuing to support the podcast. I want to take the time to remind our listeners that there is CME associated with most of our podcast episodes, courtesy of the University of Pittsburgh. So thank you, University of Pittsburgh. Please just click on the link at the bottom of the podcast, takes you to a web page, create a free username and password, answer some questions that I write that are not hard, and that's it. You get AMA Category 1 CME credit. I want to, as always, thank and acknowledge Dr. Megan Keene Tarchichi, who helps me with everything. But I really want to thank you all who are listening. Thank you for letting me come into your earbuds or your car, wherever it is you are. I really appreciate the fact that you do that. If there's anything you want to hear or think we can cover better, any comments, suggestions, compliments, whatever you want to do, again, as always, please feel free to email me at tony.tarchichi, tarchichi, @chp.edu. Thank you again, everybody. I hope you have a great day. We'll see you next time.